Thank you very much. And I need to thank the organisers of the meeting for having kindly invited me to speak here. They gave me a fairly hard topic to talk about. It's a very challenging topic. And I'm not going to talk about South Africa. I'm going to talk about the way that we have to approach some of these issues in the world. I think the first thing that we have to accept is that, yes, the world is a single nation, but there are different levels in that world. We've got the developed world, which is about 1 billion people. We've got India, Russia, China, etc. We make up most of that 5 billion in the middle. And then we've got the poorest of the poor. And those are the people that we actually need to be thinking about. Right, so let's ask a simple question here. What is the global health problem? And before you all embarrass yourself, I will in fact give you the answer. The in fact developed world is spending too much money. The developing world hasn't got enough money. So the people are getting older, the pattern of illness is changing. The developed world spends too much. They have to find simple solutions. The developing world, it's a completely different problem. The people are poor. If you're poor, you don't pay much income tax. And poor countries don't spend that much on health, which means that you don't have much money. You don't have doctors and nurses. And the thing that's needed is to get medical services out there somehow. Right, so in fact, flying over, I entered all the challenges I could think of, and I had an A4 notebook, and I came down the left-hand side, I came down the other side of the page, I came down the next page, and I said, I can't do this. And I simplified it. Now, if you look at that, there's probably only one thing there that stands out as not being something that you had thought about. In fact, political agendas. Sometimes in countries, they use health and e-health to get votes. Their heart isn't necessarily in it. So think about that. I'm going to start with the end one, the lack of evidence. I'm very happy that the co-chair isn't in at the moment. We need evidence-based e-health. Now, I get sent around Africa speaking to ministers of health. And I'm told by my friends that it's a bone of contention. You actually shouldn't be doing this. Why? It's a bone of contention because you need to be able to justify why you're spending money on health when you're taking tablets out the mouths of the sick children that have been taken care of by, in fact, Adele and in fact, all of his teams. We need to understand what the cost of ICTs in health actually are. Now, the in fact, median spend on health in sub-Saharan Africa is $34 US. If you take 2.5% of that, that's 75 cents a head a year. So, in talking to the in fact, ministers of health, you have to give them an answer. How are they going to get the most out of that 75 cents? Is it in a district health information system? Is it in fact telemedicine? The problem is there are no data. Nobody has actually compared these, and certainly no data out of the in fact, developing world. So, the first take-home message, there's lack of hard evidence of any of the benefits of e-health, be it the patient benefits, the doctor benefits, economic benefits, society, etc. So I began looking in a bit more detail at e-health economics, and I reviewed some 2,500 papers on e-health economics, and you find statements like that. E-health hasn't assigned a high in fact, priority to in fact, dealing with economic factors, and in fact, telemedicine. Economic evaluations in fact, remain rare, and they're badly done. So as doctors doing the job, we are doing it badly because we aren't actually assessing ourselves and actually getting information out there that other people can in fact, learn from. So you get some in fact, very strange things happening. This is a paper on 4,000 hospitals in the States. Came out in fact, April of 2010. Hospital computing, in fact, does not reduce administrative or overall costs. In fact, next month, a saving of $3 billion in the VA by putting in a health information system. So you've got two completely different views. Why? Well, a whole batch of reasons. There, in fact, are not much data. Why? Because there are very few successful services which have been going sufficiently long to be in fact audited and to get meaningful data out of it. The sample sizes are small. The evaluation tools themselves are bad. It takes a long time to break even. A successful health information system, telemedicine system, takes between 3 to 13 years to break even. Most pilot studies are dead a long time before that. The costs of technology are changing all the time. In fact, large computer now, which is expensive, is comparatively cheap. The same amount of power. In fact, 4 or 5 years down the line. So, in fact, why is it that the economics of e-health have not been well, in fact, researched? Is it because it's a very complex issue? Is it because there are a whole host of stakeholders? A benefit to a patient is actually an expense somewhere else. Health outcomes are difficult to convert into economic terms. How do you convert the fact that you've saved somebody 6 months of pain into an economic value when we don't have the appropriate evaluation tools? So all of those are the reasons that we have not done this well. The, in fact, next issue, let's just move on. How do we assess the success of a telemedicine service? Is it the or is it the, in fact, number of sites which go up each year? Is it the number of patients seen which go up each year? I sat in a meeting here in India, I think in 2008, and I was astounded by the sheer volume of the telemedicine going on. And I began doing some maths, and I said there's a magic number. The magic number is 2. In fact, Scott was next to me. He said, Mars, you can't add or subtract. You don't know what the hell you're talking about. So we in fact sat down and we in fact reviewed all the papers out of the 2 main telemedicine journals, and we came up with a different way of measuring it. We said consultations per site each week. And you'll see that 60% of all the services send less than 1 consultation per site per week. 70% send 2 cases or fewer each week. So, saying that, I get told that you can't say that. That's bad. That's a bad advert for, in fact, telemedicine. I say, no, it isn't. There's a message there. When you implement a service, you must be implementing several services off the same hardware with education and administration, and then you have a service. Now, a paper that came out in fact, January talking about the quality and safety of in fact, e-health, a systematic review of systematic reviews. And it basically said exactly the same things that I've been saying. There isn't much evidence that all the things that we as the enthusiasts say actually occur. And it also supports the various points I've made, that there isn't much evidence that anybody is affecting any saving. But having said that, a systematic review of systematic reviews, you look for randomized controlled trials. You exclude, in fact, studies that you don't think are in fact strong. We know in telemedicine, randomized controlled trials are very difficult and very few. So there isn't data there, but there is data there which hasn't been included in the randomized controlled trials. So the, in fact, next challenge, in fact, strategic plans, policy, etc. The in fact, WHO said the best way of implementing e-health is to have some framework, in fact, strategic plan, a policy. But policies can obstruct. On the one hand, if you don't have policy, it can be very difficult to get things going. But on the other hand, if you've got policy which has been made in a reactive way, focusing around local events, that can actually block external telemedicine as in fact well. And something that I'm seeing in sub-Saharan Africa, you must have a policy because the WHO says you must have one. So you get a template and you make one. And is it actually in fact meaningful policy? We need to see. Right, it was in fact Thomas Friedman who attempted to convince us that the in fact world is flat. And if we are going to conduct international global telemedicine, we need a boundaryless world. So how can we achieve that? Well, we need an international e-health in fact convention that addresses, it won't necessarily solve it in its first go, but that addresses the issue of how do we practice over international borders? Who is able to in fact offer services over these borders? If somebody's sued, who gets sued and in fact where? And how are people paid? And we can learn from the EU, and we can learn, in fact, in the States over the past 6 or 8 months, several states have now allowed people to in fact work back over their in fact state lines. But we need to be careful. In the EU, we had each nation as a silo. They have come together. They've broken down their internal barriers, but they're forming one large silo, which may be harder for us to actually enter. Now, why won't that go forward? This is stopped for some reason. Right. In actually looking at global e-health policy, Richard Scott has come up with a term which was used at the very end of the talk that we just heard. Local. Now, the whole reason for talking about that is that every time you think about developing something at a, in fact, local level, you've got to think what the impact is on a global level. And if you think on a global level, what is the impact going to be, in fact, back home? Right, now we get on to the, in fact, standard issues, the same challenges we, in fact, all face, the legal and ethical issues. We in fact, all face them. However, the circumstances can in fact, differ. I don't know if you can see that. The first problem, how do you deal with a person who's downloaded all of the answers off the internet and says, Doc, you're wrong? How do you deal with actually knowing that the person you're dealing with is a doctor? I was going to say a doctor, but I stopped myself. At home, in South Africa, in fact May, the in fact headlines, phone doctors under fire, the service is unethical. The next day, the people who in fact control all the doctors in South Africa say telemedicine is unethical. It in fact condemns telemedicine. The people who insure us as doctors say this: it is highly unlikely that the MPS will assist a member who is registered with the HPCSA with any problems that arise from their taking part in telemedicine in South Africa. Now, is that helpful? We are meeting with, well, we've had several meetings with them. I've talked the Minister of Health into organising a meeting next. Right, who can tell me what that is? You've been talking about it all day. That is the first phone. And the first phone was, in fact, 1876. There's the version in 1892. And I'm going to say some things here which people aren't going to be happy with. M-Health is not telemedicine. M-Health is not e-health. It is the same as the internet. It's a way of moving information around the world. The, in fact, reason that it's so good is that it is the most ubiquitous form of information and communication technologies that the average person can easily use. And it is the way forward, but it is not something new, and it's not telemedicine or e-health. And you can all in fact shoot me down. I've told the M-Health Alliance people that over and over again. Right, the big gap. Awareness. There's a shortage, seeing I'm talking about e-health, I'll be focusing on, in fact, telemedicine. There's a shortage of people in the field of medical informatics. We lack in e-health in general awareness, training, and formal education. Who ought we to be teaching and educating? Doctors, nurses, the support staff, the site coordinators. But something that we forget, there are two very important groups that we forget. The governments don't know all that. In fact, governments don't have the enthusiasts in government. We have to educate government. We have to raise their awareness. But the most important thing, and I've been bashing my head in South Africa since about 1995, go into the communities, raise their awareness, make them demand of the hospitals. We want this. We don't want to be sent on a 4-day journey to go and see a specialist. We hold the vote, so do it. And in fact, government in South Africa is going to embark on a national awareness campaign next year. The final thing is, in fact, standards and standards and guidelines. It's very hard drawing this up. So what we did in South Africa is we stole the guidelines from the ATA. We in fact stole the guidelines on mental health, adapted them, and we have given them back. It saved us years of work. We talk about the social and the cultural areas. We need to learn from the developed world and how they've handled groups like First Nations. In some communities, people aren't concerned that the information is kept to themselves only. They're quite happy to share. Now I'm going to just end off, in fact, by giving you the 11th commandment. Thou shalt use change management. Why? Because the effect of failure holds things back for a long time. In South Africa, we embarked on our first phase 1 national telemedicine program in 1999. It failed within 6 months. It's now 2011, and we're just starting up again. The second thing is we don't budget for the expense of doing this. And then, in fact, final one. You must have will. And I spoke at a meeting with the advisory committee of the Ministry of Health on Tuesday, and I put up that slide. I said the minister has to stand up and say this. Telemedicine is an integral part of the practice of medicine in South Africa. And secondly, telemedicine has to be put into the job description of every health worker in South Africa. And then you will begin to, in fact, get somewhere. So, in fact, things change, but they stay the same. We are all still doctors. We're all attempting to make patients better. We're just doing it using completely different toys. We keep changing our toys. We need to learn from the failures of others. We need to think both internationally and nationally at the same time. We need far better assessment and evidence, and we need hard evidence.